a lot of tissue trauma. And so my concern is that it's more likely to cause an MS flare than like a smaller, simpler surgery.
But that's gonna be the case, so I mean, with MS, I could never get surgery.
No, it does not. It does not. Absolutely not. It just means that, maybe you need to be on some steroids and have that, not be in this situation right now that where the flare, where you're still sort of in this window where you have this MS flare. So he has relapsing remitting MS. It's been the flare started about a month ago. He has
But it's been longer than that.
longer than that. So typically it's
What I'm saying is, over the past few years, I've been in, because I haven't been on any medication with MS.
yeah.
So it's not like I'm gonna get better at any point. It's gonna remain as it is. Nothing's gonna cause the MS to not be there. So my thing is like, this is the major issue I'm dealing with right now.
Yeah.
I believe once we get this, I'm weak. My leg, I was telling the doctor, I can't even get my foot up off the ground because everything's gotten weaker on this side.
I know.
And I'm saying, even if we don't do a surgery,
Yeah.
or MS is still gonna be there.
Your docs your neurologists haven't recommended steroids or anything like that when you have flares like this?
In the past.
Normally
Yeah.
they do,
In
but
the
he
past.
hadn't been in the neurology since.
In a while.
Yeah.
I've seen Dr. Maloney and Wally.
Yeah.
That she was for it. She was
Yeah.
for the operation.
Oh, I think the operation is a good idea, and I think you need it, and I think you'll benefit from it, and I think you'll do well from it. The foot drop symptoms started about a month ago.
No, I had foot drop for years.
Yeah, for years, but
Yeah.
it's been worse over the
It's
past month or
worse.
so.
Exactly. It's
Yeah.
gonna get worse.
Yeah.
The only downside to this is recovery potential right after surgery. So if you already have weakness in the leg, and I know it comes and goes, and right now it's a little worse than
It's
before.
not coming and going. It's
It's
getting
it
worse.
stayed and it's consistent. It hurts your recovery potential. So how does your other leg feel?
Great.
It's not no weakness or anything like that? Okay. What do we think? I mean, from this standpoint, I don't think his strength is going to get better in his leg. It has been like this for a few years in terms of his weakness. It's certainly worse now than at baseline. But
Due to this.
well,
I mean,
I don't think we should do a spinal.
No, definitely not doing a spine. He's got neurogenic bladder. And,
Yeah, no spinal.
and my leg will get stronger. I'll work hard. But I'm not going to relax on rehab and
No, I know you're not. I know you're not. It's just there are limitations to what you can overcome. But
who are your neurologists again?
Mitch Wally and Heidi Maloney.
they're here, correct?
Sorry. Can you spell their names for me?
Wally, W-A-L-I-N.
W-A-L-I-N.
Yeah, and Mitch Wally is first.
Mitch is the first
Mitch
name?
is first name.
Uh-huh.
And
Who's the other person?
Heidi Maloney.
Maloney?
Spelling that.
M-A-L-O-N-Y, I
Uh-huh.
think.
Heidi.
Heidi.
Okay.
Lone. Yeah.
Okay.
What do you want to dose them with steroids before the surgery?
I want to talk to the neurologist.
Yeah, see what they think.
Yeah.
Okay.
It seems like we would have done that before.
Well, it's only been a month that it's been bad. We did your pre-op before that because you got canceled. So we
Two
saw you.
times.
Yeah, I know.
Yes, I am
We-
aware.
We saw you before your flare kind of started up again. We probably saw you close to 6 weeks ago now, so I think we just missed the back end of it. I know they cleared you before. We did talk to the neurologist beforehand, and they had cleared him, but we just want to make sure there's no difference now because it's kind of a month old.
Yeah, talk to them.
Yeah, we'll see what they think. All right, I'm gonna sign it, or I'm gonna mark it, okay? We all agree right knee's the correct knee, yes?
Yeah.
Okay. I'm gonna write a big yes here.
I'll go make some phone calls, I'll try to get in touch with your neurologist, okay?
How old is this in Susan, remind me?
About 10 years.
10 years, okay. We'll use... I don't think I'm gonna use it. I don't like where it is.
You don't like it?
No, it's a little medial. I try to use it where I can or where I have to, but I can just move your incision closer to here, which still gives you quite a bit of,
Okay. That's good.
yeah, I think it should be fine. Surgery itself only takes about an hour to an hour and a half.
Okay.
Implants are designed to walk on right away.
Right.
Physical therapy will get you up and get you moving.
Okay.
Okay. And if you clear therapy, go home today. If not, go home tomorrow. You have a full-time aide at your house, correct? Who helps you? So that's good. That's helpful. So I do understand where Dr. Ramadali is coming from. So one, we won't use a spinal anesthesia on you because that's just asking for trouble.
Right.
Your nerves are already incredibly sensitive, so we really can't like flick them or irritate them because that could disrupt them.
Better though, you know.
Yeah, no, it won't make them better. I can almost guarantee that. Well, you never know, historically, so it will make them worse, not better. The one thing I worry about after surgery is you have a baseline level of weakness after the surgery, right? I have to cut into your quad muscle to do the surgery, et cetera, et cetera. If you have too much weakness in the operative leg, it becomes difficult for you to ambulate or get around. Now, I know your other leg does all the work now. Most of the work now.
Right.
But whether you realize it or not, this leg is still doing work.
Maybe.
It is.
Yeah. Okay.
You wouldn't be, if it was doing no work, you wouldn't be walking at all.
Mhm.
So it is,
Yeah,
it's doing more work than I think you probably fully appreciate.
Yeah.
I
I mean,
and-
this used to be the weak leg
Yeah,
before I got the
Yeah.
MCL thing.
yeah.
Hey, how do you know?
And this became, since this been going on.
Yeah, that
This
became the
is the
sharp
major,
leg, yeah.
yeah.
So can you lift that leg up off the, good, that you have no problems with that? How about this one? How far can we lift this off? And that's because of this, huh?
Yeah.
I'm just afraid we might be setting you up for failure. I am worried about that, okay?
I'm telling you, Doc, it's not. I know, I understand.
No.
You're a specialist, but it's like you don't know how I feel.
I get your knee is painful. It's incredibly painful, and you feel like it's contributing to this.
Absolutely.
I'm gonna tell you largely it's not. Okay? I know you feel that way, and I appreciate that, and I appreciate where you're coming from. But a lot of this is not because of the knee arthritis, I assure you. Okay, especially not, the weakness and you're definitely having trouble lifting up the leg when you have bad arthritis is possible. But, the weakness further down the leg, that's definitely from the MS.
But
Yeah.
like
The hip flexor weakness is
Yeah.
also from the MS.
and so is it not because, I'm not doing regular sitting, getting up. It gets weaker, right?
Yeah.
I could probably do exercise, do some.
Well, you're gonna get exercises out the wazoo
Yeah.
after the surgery. You're gonna be sitting there
Just
working
watch.
on this.
This-
Yeah.
This would be so much stronger up here.
Yeah. I mean,
Okay.
ideally, we like that to happen before you have the surgery, not
Yeah.
after the surgery, because I explained it like this. So everyone takes a step back after surgery. Everyone. If I had surgery, I would take a step back. That's just the recovery of surgery. If that step back, if you already are starting, so if you start up here, so let's say this is your threshold for functioning. If you start up here and take a step back, that's okay, you're still well above the threshold. If you start down here and take a step back, you've now dropped below the functional threshold. And that is very difficult to come back up from. That's why I caution you. There is a chance when you don't have great functional capacity in a leg before surgery that the inevitable drop that you get from the surgery itself results in your function dropping so low that it cannot recover. That's the only thing I'm trying to caution you about. I'm not saying it's going to happen to you, I have lots of very motivated patients that it doesn't happen to, but it is a risk when you're starting low already that you drop below that acceptable threshold. What I'm talking about is if your weakness in your leg is right now you're managing. You can get up, you can walk around with the crutches or whatever and doing okay. If we drop you below a threshold where you can't use these anymore because the leg is not strong enough to support it and now you're in a wheelchair, you may see that as a temporary thing. However, it becomes a self-fulfilling prophecy. You're in the wheelchair, which means you further decondition your other leg and all the other muscles because that's the only way you can get around initially, and then it starts cycling and deteriorating. So my whole goal in life is to make you more functional than you start.
Right.
And when people start up here, it's very easy for me to guarantee that. It's not saying that we don't do this today. I just want you to make sure you understand that if we start down here, I cannot give you the assurances of function the way I could if you started up here. Where if you drop below this level, there is it's still a small chance, but it's a larger than say my chance that I don't make you better from a functional standpoint.
Right.
And that's all that is. I mean, don't get me wrong. This is a pain relieving procedure and I know you have pain in your knee. But I don't want to do something that would take you below a functional capacity that is independent.
Well, if it's
And
not
to the
just
place where
pain,
you
but
already-
this is all weakness too. I can get to a position with this leg right, it's going out. It's that weak.
Yeah.
And so-
I understand that. And I'm not saying that all of the weaknesses, like some of the weakness very well can come from the knee. You're not the first person who have had knee arthritis who has buckling of their knee because they have weak
all the time.
quads.
That's it, right?
Right, and I understand that. But I want to caution you that because of your MS, we cannot guarantee that that's where the weakness is coming from.
Okay.
And if it's not coming from the knee, if it's coming from an MS that's getting worse, this surgery does have potential to set you very far back.
Okay.
That's the only explanation that I'm trying to provide.
Okay.
Not saying that I'm not going to do it, but I like patients being informed. I don't want you coming back in 6 or 8 weeks and saying like, you told me this would get 100% better and that's why I have all this weakness in your leg. And I want to clarify that that is not the case.
Now let me ask you.
Yeah.
I have weakness here.
Along the side there.
If
So
we're not-
that's not so much. I can definitely justify some quad weakness because of knee arthritis. The weakness you have in this muscle right here, down into your foot, that's from your MS.
Okay.
100%. That's not coming from the knee.
Yeah.
That's not a traditional muscle weakness that you get around a knee replacement. So I don't want you to think we're gonna do this knee replacement and your foot drop's gonna get better. It's not.
Okay.
Okay, that's not where that's coming from. Now pull your foot up for me. Pull it up. As hard as you can, hard as you can. Okay, not terrible. 4. It's gonna be worse after surgery. Okay, just because the inherent, it's trauma. You got swelling in the area, you got, So we have all that. Okay. Let's see what Dr. Ramandali gets a hold of the neurologist, make sure that because the other thing is, do they know you're in another small flare right now?
She knows this foot drop anyway.
Yeah, not the foot drop. That's I mean,
I
that's
don't think so.
okay. We just want to make sure they don't have any other recommendations for that. We're just trying to be safe. The last
Yeah.
thing we want to do is make you worse off than you started.
Right.
Okay. The
Yeah.
whole point of the surgery is to make you better.
Yeah.
And I know you've been waiting a long time for this. I know. And I talked to you a while ago, and we were both in agreement. You need a knee replacement.
Right.
But I want this to be the safest knee replacement we can give you.
Okay.
Okay. So let's get an answer from them first, and then we'll go from there.
Okay.
Sounds good.
Do you have any questions about the surgery itself?
Not the surgery.
Okay. I know you're easy peasy on that. You're set and ready to go. Okay. Give us a few minutes.
Thank
We
you.
got time anyways. We're opening the trays and stuff in the room, so
Okay.
you're okay.
Yeah.
All right. And I'll
All
be
right.
back.
Thank you.
Yep.